Okay, well, thank you for staying along. This is the last session. So I'm Bruce Arrell. Hopefully people know who I am by now. And my colleague is Linda Bryant. Linda's a clinical pharmacist, used to be based in our department, has sadly fled to Wellington. But I was reflecting the other day on when I trained in medicine, there were people called clinical pharmacologists. There were Evan Begg, Linda Bryant, David Black. And those guys have disappeared and retired or died. And then people like Linda have come along because she understands primary care prescribing. Like if I have a prescribing question, I'm emailing Linda in Wellington, and she's wonderful because she gets back to me within about 24 hours. So if you'd like her email address to get these answers. So I think the clinical pharmacists have become our port of call when it comes to this. So we've got a prescribing update. And we're keen to get through it. So Linda's got no conflict to declare. I'm on the Pharmac Education Committee, and if you haven't been to a Pharmac seminar, go. They're all fantastic. The feedback is phenomenal. You pay $100, you get a flight to Wellington and back whenever you want, sort of thing. And we do education work for Pharmac, although nothing I'm saying today, I'll be imploring you to use fewer antibiotics and fewer antidepressants. And it's got nothing to do with what I've done for Pharmac. I've been on about that long before I had anything to do with Pharmac. So I wanted to show you this. This is an interesting slide. So this is systolic blood pressure along the bottom here, and then what happens to your ischemic heart disease mortality up on the y-axis, and this is age. Now, there's no such thing as hypertension, as Rod Jackson would say. And if you look at that picture, you can't tell me where hypertension is. So here's a 40-year-old with a blood pressure of 180. Hope you can see that. And here's an 80-year-old with a blood pressure of 120. This is logarithmic. The 80-year-old's got a way, way bigger chance of having an event than the 40-year-old. Not a good blood pressure to have as a 40-year-old, but most of these people, you've probably got patients, when you've been around as long as I have lived a very long time with untreated blood pressure. I wouldn't recommend it, but as Ralph Stewart said in the last session, the earlier session, you really are treating people for avoiding an event 20 years ago. If I see a 50-year-old, I'll say, I'm giving you this medication to take every day to avoid a stroke when you're 75, because that's about how long it takes. So it's a very long-term gamble. So my question to you is, I'm going to give you 5 years of antihypertensive medication to give to 100 people up there. Who would you pick? Well, we'd probably all emotionally pick this group, but actually we'd do nothing for them, because a 5 millimetre drop in blood pressure there is going to have a fairly small, but up here a 5 millimetre drop of blood pressure is going to have a massive effect, like 60 times. Down here it's going to be about 8 or 10 times. Now, of course, we're not in that situation, but it's just to get you thinking about these people, because I'm going to talk about treating older people. Sorry, that's as good as we can do. Oh, okay. So up there, let's go up there. You drop 5 millimetres. Can you see this little thing? No, okay. So you're up on the 80 to 89 graph, going from 120 to 180. If you drop 5 millimetres, you're going from about 80 down to 64. If you come over to the 40 to 49, and you drop 5 millimetres from 180, you're going from about 15 to about 8. So the big bang for the buck is with the older people. Everyone's worried about making the little old ladies fall over, and I've made little old ladies fall over. Nobody's broken their hip. But we also have to remember they also are the people who are going to have the stroke. And if that's your mum and dad or grandma and grandpa, you probably don't want them to have a stroke when they're 85. And I think it's about informing them appropriately with the correct information, not making a decision for them. I mean, if they look like they're going to die in the next week, then you wouldn't bother having this discussion. But this stuff is based on the SPRINT trial. This is looking at the older group. So the SPRINT trial, I can't remember the age range, but they had a bunch of people over the age of 75. So the goal in that study was to treat to less than, that should be 130, it's got 150, rather than less than 140. Sorry, no. Okay, so this is JNCAT, this is the Americans. Completely bizarre, completely wrong to have a higher threshold for older people, because you're going to put a whole lot of people at harm. I can't work out why they did that. Sorry, I can't work out why they did that. This is the Americans, JNC8, they put their older threshold up to 150, and for younger people, 140. Completely, epidemiologically, back to front. It's like going back to when I trained as a medical student, 100 plus your age was okay. None of us would think that. The JNC, and they're going to change that, particularly after the trial. Okay, so in the sprint trial, there were 9,000 patients, 2,636 over the age of 75. It was stopped after 3.2 years. And these were people with high cardiovascular risk, so 24% 10-year risk. So pretty well all these people had had an event, or else they have had massive risk factor problems. None of them were diabetic. Blood pressure baseline was 142 over 72. And when they treated them, they aimed to get down to 120. They got down to 123 in the intervention group, and in the control group, they got down to 135. Numbers needed to treat 22. Now, we know from the HIVET trial, which was very, very healthy 85-year-olds, very healthy, and you've got to take into account how healthy they are, but a very healthy 85-year-old with a high blood pressure only needs about 5 or 6 people to be treated to prevent an event. One of the best NNTs in medicine. We don't do that very often. NNT of 22 to reduce blood pressure. So this was the composite index of blood pressure events, 15.5% down to 10.5. Death, only had to treat 38 people to get that. So how do we explain to patient? Well, this is my view of how we should change things. I say to patients, you're the boss, I'm your advisor, and here's the information. So I use this. This is James McCormack's chart. Now, it actually doesn't work at the moment for that because he's always assumed treating below 140, but I just made up these numbers. So I show this to patients. It works incredibly well for getting someone to take a statin or not, because you cannot explain to somebody what the benefits and harms are without some numbers, according to me. And I'm surprised. I'll show this to somebody, a 50-year-old. This would be a 50-year-old for primary prevention for statin, and almost all of them say they're not interested, whereas we as doctors would probably think 4 out of 100 was pretty good. So that's my values, but their values are, me take a pill every day for the rest of my life? For that? You know? Okay, so the colours mean these are the people who, so here we have 14 people having events, and if you take a medication, let's say it's a statin, 4 people will get a benefit. So these people are still going to have a stroke or heart attack or event, and 4 people will benefit. And the rest get no benefit. So most people don't benefit from most drugs. I'm going to talk about antidepressants afterwards. And with antidepressants, they have a response, but it's almost always placebo in the population we're treating. And I'll show you the data for that. So I show patients this. I print it out for them. They can take it home. I've got a lady at the moment whose blood pressure is about 150. She's a very fit 83-year-old. She's traveling overseas all the time. And I said, take this home and talk to your daughter about it. So this is on the therapeutics collaboration. If you look back at one of my gyms, I talk about this. And as I say, even when people get up to 8 or 9 or 10, this is over 10 years, 10-year benefit, people aren't interested in taking statins for primary prevention, which I would be, but you know, and I consider them fully informed. I don't think I can, you know, I remember talking with this guy, and he was saying, well, should I, shouldn't I? And I thought, well, I can't say that to you. You know, and then I suddenly went back and had a quick flick up the numbers. Okay, so this is what happens if over 3 years, so you multiply it by roughly 3, so it would be 10 people over 10 years over the age of 75 would get a benefit from having their blood pressure lowered from above 140 down to 123. That's what you get with younger people. So the bigger bang for the buck is with older people. The numbers needed to treat are lower for younger people. That's all the people in the trial. Again, you have to multiply that by 3 to get up to 10 years, because the study finished with that. Okay, so the downside would be 3 versus 2 drugs. There was more hypotension and there was more syncope, but there were fewer serious falls. Now, I think what happens is you're getting rid of the TIAs and the little strokes that we don't pick up that knock people over. So I suspect that's why that difference would be my take. The electrolyte disturbances are a problem because they were using chlorthalidone. Diana said to me earlier that she's heard the gerontologists don't like it because it causes problems. I had a look, I couldn't see any problem. It was used in the SHEP trial. It's certainly very effective. If you're going to use a diuretic, it's probably the one to use. There was a more acute kidney injury. Now, acute kidney injury is your creatinine goes up within a week or 2 of taking medication. See, a lot of these people would have been getting SSRIs, not SSRIs,
ACE inhibitors?
ACE inhibitors and ARBs, which in a certain number of people, if you've got renal artery stenosis, and a lot of these people will, through atherosclerosis, will put that up. So I don't think, and it may be lowering the blood pressure, but they did benefit. They did benefit from that. What about the frail elderly? Okay, actually had fewer falls, and it may be protective to treat the very high risk. Again, these are this would be somebody who's pretty fit, but my 83-year-old lady who's going off to Europe in a few weeks on a trip is pretty fit. So I'm actually pretty keen she takes the medication, but I've given her the numbers, and I just have to keep my counsel. Okay, so this is going to be tricky without a thing, but the top line there is in terms of fragility. This is a fragility index. I won't tell you what the details are, but it measures fragility. There's about 30 different things. Doesn't make much difference with the people who are fit. The next graph is for people who are moderately fragile, and then that's the most fragile. So the biggest risk, the biggest benefit is actually in the most frail people. Almost statistically significant, not statistically significant, almost. So if we're worried about frailty, I think we need to take a step back. And to me, it's about informing patients. It's not about making, I think we get our values stuck in this and not the patients. And my patients particularly compos mentis, she can make the decision. In terms of the trial, they aimed for 120, they got 123, and there's been some modelling work suggesting actually 123 is not a bad way to aim. I use the Vancouver chart to suggesting it's the therapeutics collaboration. If you go back to the gem, you can find it. Clearly, you want to think about hip fractures, and you might want to think about chlorthalidone. It does cause problems with electrolytes, but it probably has, it's long-acting and it probably has other benefits. The reason why it seems to be more effective than the other diuretics. Linda, beta blockers.
But just before that, I mean, the thing about that study, the main thing, and we've been saying this while, is that blood pressure lowering tablets themselves don't necessarily cause falls if it's postural hypotension, but for some time, just giving them the blood pressure lowering medicines isn't going to be, oh my gosh, they're old, they're going to fall over if we give them a blood pressure lowering medicine. It's actually, if it's postural. So I think we have to remember that, because as much, this whole polypharmacy thing, which we'll get to, is an issue of sort of saying blood pressure tablets themselves, if they're not causing postural, aren't going to make them drop.
Yeah,
So,
and there was a benefit, actually. They're less likely to actually have serious falls if they're on medication.
Right, so first one, we're into beta blockers again, mainly because it ties up with blood pressure lowering, but also because we've got supply problems. I thought this might have finished after a year, but we still can't get hold of metoprolol. Patients get confused because they only get 1 month at a time. But there's also the clinical issues. So this is a very fast revision. Please definitely use them in heart failure. We're probably not quite getting enough. Even if their blood pressure is low, that seems to be, oh my gosh, their blood pressure systolic is 130 or 125, we can't give them their beta blocker. You can still give them their beta blocker. So just to remember to do that and make sure we get to a decent dose. If they're on metoprolol, it's a real problem because you can't get it. Please switch to bisoprolol, because that's just as good in heart failure as is carvedilol. Bisoprolol, however, is once a day, and later we'll do about how to do that switch. So heart failure, please use them bisoprolol is fine. Easier for the patient. Atrial fibrillation, again, beta blockers are really good. It's a pragmatic choice. Well, I don't know about Bruce, but I find it's pragmatic instead of using diltiazem because we have issues about diltiazem in heart failure. So a lot of people with atrial fibrillation have heart failure. Start the metoprolol, or start the beta blocker.
And I'm completely over calcium channel blockers and swollen ankles. You know, the amount of gastric mucosa that's gone from me on swollen ankles is legion.
Yeah. I had a look at about 150 patients. A third ended up getting swollen ankles. So anyhow, for that one, just when you're switching to bisoprolol, it does tend to have more bradycardia. So just conservatively, don't go for an absolute equivalent dose, but you can switch just as easy to bisoprolol for that one as well, or carvedilol. So just as good.
And bisoprolol's been shown to be just as good in heart failure, hasn't it? So it's equivalent. It's not got the track record here, but my patients just get sick of having to come back to the pharmacy every month, so they can get 3 months of bisoprolol. There's no supply problems.
And I'm getting tired of them ringing up saying they need a repeat after a month when you say you've got 2 left at the pharmacy. Because it's just out of kilter for them. So it comes to myocardial infarction, which is an interesting one, and basically on that one, can the beta blocker be stopped? And so there's some choices here. Basically, we're saying in the guidelines up to 12 months, and if they don't have heart failure, then, and if they aren't at high risk of a recurrent MI, then actually the beta blocker can be stopped. And again, we will go into how to actually do that. I've put up there something. And the reason it's up there is when you get these slides, you'll be able to go into it. And that's just to give you an idea about the risk of a recurrent MI. Needless to say, if you've had a STEMI and if you've got heart failure, then you're going to be at greater risk of an MI. So you probably wouldn't stop the beta blocker in that case. And the reason that we've changed, if you're at my age, beta blocker was for life after an MI. Reperfusion and better treatments with statins means that the beta blockers aren't having that much of an effect. So myocardial infarction, think about it, perhaps talk to the cardiologist if you want to, but you might be tapering down and stopping.
And,
Go on.
No, you're about to...
yeah, we're about to hit Bruce's favourite topic. Now we get into the blood pressure.
I love beta blockers, though. I really do like beta blockers.
Yeah,
I take a beta blocker.
Good. Oh, that sort of calms them down. So now we're actually looking... If they happen to be on metoprolol, the big issue that's come out from the beta blockers is they're no longer first or second or even third line for high blood pressure. Is it worth switching them? And the hassle of switching, I can accept that you're probably going to leave them on it. But in this case, it's causing problems with the patients having to pick them up. They're not necessarily so good. So the idea would be tapering the dose over 1 to 3 months, so it is a bit of a hassle, and switching them to clothalidone if they don't happen to be on it already. And strangely enough, there's a lot of people with high blood pressure not on any thiazide, let alone clothalidone, which should be still one of our first choices. If they're on metoprolol, again, basically, and they're actually on other blood pressure lowering medicines, basically it's switching to bisoprolol or carvedilol. So that's the beta blockers again, because we have not solved that metoprolol problem, and it's the most commonly prescribed beta blocker.
I guess the tricky situation is, isn't it? I mean, in Europe now, spironolactone's number 4, and that's a tricky drug to use. I have to say it's the most difficult drug I have ever used. The potassiums are just a nightmare with it. And I think we're patients don't like it.
It's okay in heart failure if they've got grade 3 or 4 because you've had activation of the renin-angiotensin system. So in actual fact, most people with severe heart failure have low serum potassiums. It's when you do it in grade 1 or 2 or you use it in somebody. So it's tricky to use, but coming back in fashion. Oh, so this is really just so you can see them. It's to give the comparison between them to say bisoprolol, in fact, has dual excretion, so it's renal and it's hepatic, so that's an advantage, and it's once a day, so it really is just to cover that.
And atenolol's really out, isn't it? I mean, atenolol would be something to switch, I think. That would be considered...
so last century.
Yeah. I mean, the problem is it lowers the blood pressure peripherally, but probably not centrally, because in the next 10 years we'll be measuring central blood pressure. They've got these blood pressure machines. We had one in our clinic on trial, and it's measuring the core blood pressure, which of course is what you want for your coronary arteries, at least maybe. And atenolol doesn't seem to do that, and that's why it's why it's got, and the trial evidence is not that good for it. And certainly, losartan was better than atenolol in the life trial.
study.
So,
I think we're getting that to the essential stuff.
Yep.
That really is just looking at the comparative. If you're going to be switching, that's the comparison that we'll be using. It'll be on the website.
okay.
It's not me.
That's not new. So causes of insomnia, different ways of treating insomnia. Well, there's a bunch of different reasons why people get insomnia, and you do need a diagnosis. And I'm going to talk about an alternative to giving people benzos, because this is the condition that people end up on benzos. I've become the darling of the rest home talking circuit. I get invited to talk about insomnia. And I mentioned, well, there's a little bit of it. They say, is there any problem taking Zopiclone? Because half of them are on Zopiclone. And I say, well, no, but there is a little bit of evidence suggesting maybe it increases the risk of dementia taking benzodiazepines. And of course, you know, that causes an uproar in the place, and they all want to know how to come off it. So I say, don't do that in a hurry. You should never stop a benzo quickly, basically, because it's pretty unpleasant when you stop benzos. Anyway, so these are the causes of insomnia. None of them will be a surprise to you. So depression and anxiety, big ones. Sleep apnea, getting bigger. General health problems, breathing, pain, that's another cause. There's the weird ones, the parasomnias, the sleepwalking, talking, restless legs, probably about 5%. We got a funny answer. This is from our own work. This is New Zealand data. It's their only data on a general health clinician. Alcohol problems, substance abuse. Delayed sleep phase disorder, which is adults who sleep like teenagers. These are adults who go to bed at 4 o'clock in the morning and wake up at 2 o'clock in the afternoon. That's its own problem. Primary insomnia is the one. Now, primary insomnia, I think, is the reason why most people end up on benzos, and it's because they spend too much time in bed. So you ask these people, how long do you spend in bed? And people can tell you that pretty accurately. I go to bed at 9 o'clock and I get up at 6 o'clock. How long do you stay asleep for? And sometimes people can tell you 6 hours. Okay, well, if you're only spending 6 hours asleep, you only need to spend 6 hours in bed. Otherwise, the way I explain it, simply, is that you're diluting your good sleep out over your 6 hours of good sleep over 9 hours. And we all know there's nothing worse than lying in bed and not being able to sleep. It is in a developed country, it's a form of torture. And so the solution to these people, there are a few apps, and one of the things I do when I have trouble sleeping is I listen to a podcast, not a Goodfellow podcast, but I listen to history podcasts, and I fall asleep invariably within 15 minutes. I've got 3 American political podcasts, and I almost am always asleep. You can turn them off with your phone. You can turn them off after 15 minutes. I want to do a trial, but there's this thing called My Sleep button, and this just says nonsense words to you, like counting sheep. It'll say, you know, farm, house, mountain, skiing, basketball, rugby, sleep, or listening to podcasts is another thing, but don't listen to your Goodfellow podcasts while you're trying to go to sleep, or you'll have to listen to them again, which is what I do sometimes. Okay, so time and bed restriction. This works. We did the randomized trial. So if you want cognitive behavioral therapy for sleep, the biggest part of it is time and bed restriction, and we got 75% of people sleeping better. There's not much more room but also I think the other thing is you have to get people to be willing to not sleep, because as you know, we all do, if we're not sleeping, we get a bit obsessed with it. So you've got to get people to be willing to not be obsessed about sleep and give this a go. So you ask them how long they've been in sleep, how long they're in bed. That's easy, people can tell you that. Some people can tell you how long they've been asleep. If not, there's an AASM sleep diary. If you put that into a web browser, you can get that. And it's a piece of paper that people just fill in when they're awake. And that's quite instructive for them, because they think they're awake all night, but actually they're not. I had a guy, he would not listen. He said, I only sleep 2 hours a night. I said, well, that's not possible. Physiologically, you'd be dead. You wouldn't be sitting here. No, I'm only sleeping. He went off and had a sleep study, and he was asleep for 7 hours. So he can, really. But I mean, he was not having a bar. He thought I was weird. Okay, so then you say, go to bed later, or wake up earlier. But usually it's easy to go to bed later, and so they need to spend 5 to 6 hours in bed. Some people won't make that change; it's too big. Spend less time in bed. So if they wake up at 6 o'clock in the morning with the family getting up, if they live with a family, then they need to go to bed at midnight. interesting thing in our trial, the most difficult thing people found was keeping themselves occupied to midnight without looking at a screen. Really quite interesting. There's a real problem. People don't have hobbies or cards or read. You know, that was the biggest complaint. So this is on top of sleep hygiene. Basic sleep hygiene is amazing. 35% of people will get better. So we suggest them doing light housework, ironing the pyjamas, you know, all sorts of useful things
So
like that.
what are the women going to do if the men are doing that?
What, I don't know. I'm sure men will find some task for women to do. Men historically have been pretty good at that, actually. We're very good at those things. You may be drowsy the next day, but if you're still drowsy the next day over a period of weeks, then you need to, you may be a little sleep deprived, so you then spend a little bit longer in bed. You need to spend at least 15 minutes, you need to spend at least a week trying a new sleep pattern before you abandon it. The odd person resists this. We had one person in our trial of about 100 people, and we got her to sleep compress. So she went down from 9 hours to 8 hours to 7 hours to 6 hours. But pretty well everybody, we said just sleep 6 hours. And they come back to you and they say they start sleeping deeply. We had one guy say, that's the best sleep I've had in 30 years. Boy, do I feel good when that happens. Numbers needed to treat of 3. Again, much better than just about anything else you're doing, folks. I hate to say it. I tell the medical students, most drugs don't work for most people, and they all laugh. And I say, okay, well, how many things do we do have an NNT of 1? Isotretinoin for acne, penicillin for meningococcal disease. After that, in primary care, there's not much. And if it comes to primary prevention of heart disease, it's like 60 to 100. So they get very quiet at that point. You do need, so they notice they get a deeper sleep. And as Tony Fernando says, when you're not sleeping well, it's sort of like snorkeling on the surface. And when you start having an appropriate amount of sleep, you start getting not quite as good as you had when you're a teenager. You know how teenagers have that incredible deep sleep. And now, if they're professional drivers, they do have to do it when they're on vacation. And if you want to get people off benzos, what you can do if they have a partner, it's a bit tricky if they haven't got a partner, but you may be able to get a pharmacist to make up lower doses in a liquid form, is crush up the benzo into milk and add a little bit of flavouring, vanilla flavouring, and then the partner decreases the dose over a few months. So that decouples the person from having the bottle. There's nothing easier than having a bottle of pills by your bed and not sleeping and just deciding to take one. So you've got to get that behavioural connection out of it. So
Code of good manufacturer practice. I just say chip some off with your fingernail.
But you get the trouble is you get down to the last quarter and then it's then the brain says, oh my God, I haven't got any. I'm not going to have a good night's sleep, and then you take it. So this disguises it, blinds you to the dose. Yep.
We actually need more N=1 studies, to be quite honest, with people.
Yeah, absolutely.
Okay, we couldn't go past this. We know about polypharmacy, and I'm not going to ask or tell you or suggest you stop statins, because that's, as you're well aware, a major conversation with people, that it's not as easy as people may say. So let's just look at some that you can do on Monday. So really the first one is the bisphosphonates, because they're very popular, they're very effective, but after 3 to 5 years it is possible to have a bisphosphonate holiday. So I've really just put in there that if someone's low risk, after 3 to 5 years, the way bisphosphonates work, they lay down in the bone, so you can imagine they actually poison the osteoclasts, so basically they're not going to be sort of destroying the bone. And they're going to be in there, and our bone regenerates every 10 years or so. So they're going to be in the bone a long time. So if they're on a low risk, so baseline DEXA, if we're looking at T-score greater than -3, let's get that the wrong way around, you can stop it. If they've got a moderate risk, so their initial T-score happened to be less than -3, but they haven't had a fracture since, then basically you can stop them if you do another DEXA. That might be hard to get, so just having a look at what their risks are. I don't know, but we can get some measures to look at actually surrogate endpoints if we're looking at the P1NP concentrations.
You can order them. They're easy to get in the lab. But I had this funny experience. I was interviewing Ian Reid, who's the god of osteoporosis internationally, and he said, you do a P1N1. I said, what does P1N1 stand for? And Ian went deathly silent. He says, I can't remember. So we edited that out, I think. I don't think we left. I think we did edit it out. The nice thing with podcasts, you can edit the odd blip out. So that was very funny. I thought, here I was thinking I didn't know what it meant. And I thought, you must know. He didn't know what it was. So
that's something that can be quite useful because, these bisphosphonates, and particularly, having to take it every week and having to remain uptight. The other one is the zoledronic acid, so the infusion that you can give, again, with Ian Reid, is that giving it 8 monthly or even 2 yearly is fine.
18 monthly.
18 monthly,
yep,
sorry.
Just 18. 8. Yeah.
18. If we do that, it's fine because it's in the bones for that long. So if you did that, so that's about 3 infusions over 5 years, then after that, just give it every 3 years. So that's the bisphosphonates. We're using a lot. We're not going to go into the potential adverse effects, but they can be stopped abruptly. There's no titration required.
The thing that amazed me about the randomised trial with the zolendronate, actually, it was life-saving, wasn't it? Actually, there was a mortality gain through having zolendronate. It sort of knocked my socks off because I thought, well, maybe they're not that. I had my doubts about the bisphosphonates, but that sort of changed my tune.
Yeah, and I find that one probably a bit easier to use, except there's the cost for the infusion.
Yeah, we have a nurse who I don't know if Anna's here. Is Anna here? She does the zolendronate infusions and looks after our patients with bones. So bone problem goes to her.
So the potassium chloride, as we were just sort of talking about, something else to stop abruptly. And I've put up there how much potassium is in our diet. So we're better off to actually get the potassium in the food. And once you sort of stop it or reduce it, then do the serum potassium just in case. Because if there's resistant low or hypokalemia, there's 2 things. It might be that someone's got a low magnesium, could have been on diuretics. So magnesium's low, and until you get magnesium up, potassium will be a bit resistant. Or else, if they've got heart failure, it's going to be quite normal to some extent that people in grade 3 or 4 heart failure are going to have low serum potassiums, but then spironolactone would actually be a more appropriate agent for that. And the other one is we used to have this rule when I first started that if someone gets furosemide, you give them 2 slow K tablets because they're on furosemide. Generally, the body's good enough to actually cope with that. So we still have a lot of people on slow K, and that's another supply problem, I gather. Very hard to get, has to be under Section 29. So if you can stop it, that would be really good.
The supply of avocados is pretty good because avocados don't ripen until you pick them. Did you know that? So they stay on the tree, they don't start ripening until you pick them. They will eventually rot because Rose Lightfoot and her partner have an avocado farm.
All right.
So straight from the horse's mouth.
All my ones in the fridge go off. Okay, so this is just to go into the beta blockers as we talked about reducing them in high blood pressure and that sort of thing. These do have to be tapered if you can. If it's a massive adverse effect, then obviously you just stop it. But if possible, this is a bit of a problem in that you have to sort of halve the dose every sort of 2 to 4 weeks. And the reason for that is that there's the upregulation of the beta receptors, particularly if they've been on beta blockers a long time. And so you're going to get that rebound in the heart rate and the blood pressure. And it was one of the early studies, the Merit HF, I think, MI. But anyhow, it was right back there where they showed that the events were happening about a month later with this. So just to be wary, if you can, beta blockers should be reduced slowly when you're taking people off that. Antidepressants, because after you've heard Bruce talking, you'll think, maybe we should. This is more warning for patients, and I see a lot of people where they've said, I stopped my citalopram, whatever, I stopped it and I felt really bad. Now the thing is that is probably the discontinuation syndrome. So they might have been quite correct in deciding that they wanted to stop it, but someone forgot to tell them to taper it. So just to make sure there, if you have a look, the difference between the ones in yellow are actually discontinuation syndrome symptoms that they might get. So it's really worth clarifying when they come back. Otherwise, they come back and say, I want to go back on it. Well, it might not be that they've got depression.
And it feels they can feel like the depression, anxiety are all coming back.
So they automatically go back on it. So tapering for that's important. Halving the dose, sort of going every 2 weeks, halve the dose. And when you get down, you can even go to alternate dosing or half tablets.
Would you go to alternate days with paroxetine with its short half-life? You're not worried about having none on board?
Once you've gone down slowly enough, then It's one of those that you can let the person decide themselves often. You say, this, we don't want you to do it faster than this. These are the problems. If you're doing well, then you can just keep going. Let them titrate the dose. It gives them more power over it.
What about going on to the dispersible fluoxetine? We didn't talk about that, but that's...
Fluoxetine's less of a problem just because of the long half-life, but I wouldn't
There's a liquid
switch
form. I was
them.
just thinking the liquid's easier to...
Dispersible tablet for that one.
to go. So there's a funded dispersible fluoxetine. If you can switch somebody over... And I'm going to suggest not using paroxetine anyway. That's one of my little things. So stop using paroxetine.
So
for this problem, because this is the problem.
Yeah, this is how you stop it.
And you'll never get them off it, basically.
And the last thing for this one is really those PRN medicines, and I sort of see it, for some reason people might get a regular amount, be it 100 or 50, 100, 150. For some reason they want the same amount of PRN every 3 months. Got to be a problem on that one that you've got it right. So that's just really making sure, because of these things in the community, any sort of unwanted medicines, children, PRN medicines, do consider not necessarily stopping them, but watching out for the amount and making sure that people aren't hoarding them and having a whole lot at home, just because we keep automatically repeating PRN medicines.
Okay, so topical antibiotics. You will have seen the GEM, which came out, which just did stop using them, basically, and that's where we're heading. Fusidic acid, the resistance rates are 50%, and I don't think we can afford to keep using it if that's going to happen. Really, the only place for it is nasal eradication, unless somebody's got one little impetigo. Otherwise, it's now recommended by the infectious disease people that to use either the hydrogen peroxide or oral medication. If it's bad enough, then use oral medications. So keep for nasal eradication, otherwise we're going to have nothing, folks. And the same with Bactroban. When that went over the counter, as you remember, the resistance rates went up to that. Pimafucort. Now, I don't think I've prescribed pimafucort, but I did once upon a time prescribe some quinacum. And I said to myself, Bruce, you don't know what you're doing, so it's okay to give some quinacum. Now, when you give pimafucort, you should say out loud to yourself, Bruce, Linda, I don't know what I'm doing here. Okay? That's what you should say to yourself. And then just say no. Because look, that's the number of prescriptions in New Zealand for pimafucort. Now, our dermatological colleagues, I think if they saw that, would think we're a bunch of quacks. Because I don't think there's a dermatologist in New Zealand who would ever prescribe that. Viaderm, which is 18,000 prescriptions. That's 159,000 people saying, I don't know what I'm doing. I suspect it's the cortisone that works most of the time, if it does work. But if you're not sure, take a swab and a scraping. I'm not sure whether is it natamycin as an antifungal? Neomycin's the antibiotic, and natamycin, I don't know whether it's even an effective antifungal. We don't use it for anything else. So if on Monday, one thing you could change on Monday, I have asked Pharmac to delist it actually, but they're a bit twitchy about that because they think it'll upset the GPs. But I mean, man, that's bad news, I think. So you're never going to get the diagnosis if you use pimafucort. If it gets better, well then what did it get better to? Was it infected, fungal? Was it? And I suspect most of the time it's working for inflammatory skin things would be my thing. Okay.
Okay, so this is going to be a fast trip through all the non-steroidals. This is our Bruce, who's suddenly aged something like, 15 years, but we're still in the same health system, so we've got no major sort of development here. Got a cardiovascular risk of 10% for the next 5 years, and of course he's on clothalidone. What else would he be on? I don't quite know why he managed to get the diabetes, because he still is fairly fit and young. And he's on naproxen for he's been to the gym again, of course, because Bruce goes to the gym a lot.
This part of the story is true. Somebody said the other day, once you're over the age of 40, everything aches, and if you're not admitting that, then you're lying. But it is somebody should have told me that once I passed age 40, everything would ache. And when I take anti-inflammatories, I feel fantastic. I just feel like $1 million. Nothing aches. I've got arthritis in an ankle from an injury, and I can walk and do things. I just feel terrific.
And we haven't got you on a statin, so it's nothing to do with muscle aches from statins.
Well, that's an interesting thing. That's the problem with statins, of course, is that everything. I'm actually a very famous retired obstetrician I was having lunch with one day, And he says, you know, my doctor says stop it if you're aching. He says everything aches. He's 77 or something, you know, everything aches when you're 77.
Yeah, I sort of ache when I get up in the morning, thank goodness I'm not on a
So
statin.
this is actually an issue for me. Some of it's not correct. But I asked Linda, I want to take a non-steroidal anti-inflammatory every day for the rest of my life because my quality of life, I think it's worth it, unless you can scare me enough to... So you've got to scare me enough to not want to do that. I'm not doing it at the moment, but I do from time to time. This weekend I have taken anti-inflammatories because I needed...
You need to be walking.
I had to be pretty agile this weekend.
Well, we actually stuffed up your renal function a bit as well, so keep drinking water. We're down to an EGFR of 60, just because I wanted to make it interesting. So, Bruce, the first thing we've got a problem is that you may have a GI bleed. In an added one, it could be 1 in 50 to 1 in 100 people might have a gastric bleed. Sorry about that. What I'd want to do, because we love cascade prescribing, is actually add a PPI, because if you haven't not on vitamin O, what's wrong with you?
I get dyspepsia, so that would be fine.
Oh, you're going to have that as well?
I'll be happy.
Well, you know, if we take a medium... Now,
I'm a doctor, I like medications.
because, you know, the majority of medicines don't work for the majority of patients.
I know.
But PPI for you...
PPIs do.
So what we're going to do is, you're not going to get full dose, because that could be a problem. Osteoarthritis, you only need half dose. First lesson, half dose. Okay? So what do you think now, if we're looking up here, I've got some of your diagrams, and if you were going, you'd have it's a bit hard, sorry, you'd have a gastric bleed 1 out of 100, say, in the next year, and if we give you this low dose of non-steroidal, it will be sort of maybe 2. Now, you're not going to die, hopefully, of your gastric bleed, and we're going to give you a omeprazole, which will halve it. What do you think?
That's okay.
You reckon you'll live with that?
I'll go with that. Yeah, I don't think a GI bleed's going to kill me, and I just feel terrific on the insides. Yep.
Well, the other thing that's taking a lot now.
This worries me.
Function. Okay, so actually, if we have a look at the studies of renal function, and don't tell our renal colleagues this, it's quite interesting. They consider renal deterioration faster than 5 mils a minute. Okay. So if we're looking at risk mitigation on that one, basically, if he was frail, which he's not. 70 years old is no longer an age to be frail. You know, that's young still. We'll calculate your creatinine clearance. We're only going to give a low dose. The only advantage thing they're going to have here that's going to be a nuisance is we do want to actually monitor it when we start you on therapy. So it'll be 1 week, 1 month, and then depending on what results are, because we just want to make sure you're not one of the ones that does have a renal problem. And we have found...
And you'll be honest with me with the results?
Totally honest.
In fact, you're not making value decisions for me?
No, we're going to let you have a look at your lab results on your patient portal, because we're all on patient portals nowadays. Okay, and I keep drinking the water because we don't want you to get dehydrated. And we possibly will be a bit wary about giving you the ACE inhibitor in case it's a triple whammy, although looking up the information, and I'm not underplaying this risk, but the number needed to harm if we have on the triple whammy is about 1 in 300, because we're going to monitor
triple whammy? Because you've got an ACE inhibitor and the NSAID. I thought it was diabetes was the third one.
No, it's the ACE inhibitor, the thiazide, and then a non-steroidal.
Oh, okay. Well, I'd stop the thiazide. I would stop the
We haven't put you on the ACE inhibitor yet, though.
Yep, no, okay.
But that's okay. You'd stop thiazide, okay. And we're just going to monitor your renal function.
Okay.
So a bit of inconvenience there if you don't like needles.
That's not too bad. I'm feeling better about this. Yep.
Yeah, well, this one we could be done for being a little bit manipulative on this one, really. Okay, so we're not too sure about the cardiovascular risk. There's lots of information, not many from the randomised control studies, but more from population. If there is a risk, it's about a 20% increase that you'll have a cardiac event. Okay. Most of this, when we look at it, is high dose. So we're looking at diclofenac being 100 milligrams a day or greater, mainly 150. We're looking at this, if it's for ibuprofen, we're really looking at something like 1,600 milligrams or greater, and if it's naproxen, we're looking at 750 to 1,000 milligrams. Okay, that's when the bigger risks are coming in. So again, we're going to keep you, for your kidneys, for your GI, we're going to keep you at half dose on that. So, you've got a 10% cardiovascular risk, and after hearing the rheumatologist, you have not got rheumatoid arthritis. So what happens is that's going to increase your risk up to 12%. I cheated. I've given you here basically a 1-year risk as opposed to 5 years. So what you'd be doing there, if you weren't taking the non-steroidal, you've got 2, and if you are, you've got 2 pimafucort. So that's going to be your risk. Now, it's going to keep you being active, which is good for your cardiovascular health, but there is an extra risk.
It doesn't bother me, actually. It's interesting. It's funny. In my mind, my kidneys worry me more than my heart, funnily enough, which is odd. I mean, I could survive a kidney failure, but not a heart failure.
We're pretty good at actually monitoring your kidneys. And if your risk does go up, of course, we're going to give you a statin, make sure your blood pressure's controlled, but we're not going to give you aspirin. Because it's primary prevention.
No.
Okay?
So
there you go. Quick summary is Bruce has decided that he wants to keep taking his non-steroidal because it's his pain, his quality of life, not mine.
I might start taking it every day now. This sounds
Okay. Yeah. PRN's good.
Yeah.
Okay, so there you go. Low dose. Make sure you don't give diclofenac 75 twice daily. Add the PPI, bigger pill burden, watching his renal function, and please maintain your hydration. Keep drinking water.
Okay. So respiratory infections, 50% of New Zealanders get an antibiotic first up. So the majority of antibiotics in New Zealand are given for viral infections, in fact, not for bacterial infections. I have a iconoclastic colleague in the UK who says we should only prescribe antibiotics when we've got a positive bacterial culture. So that would really trip us up. And I know it's difficult to stop giving antibiotics to somebody who's medicalised, but remember, it's us, GPs, nurses, primary care prescribers, who got them medicalised in the first place. I would suggest decongestants, and it's a pain in the neck to have to get out the control drugs form to give pseudoephedrine, but no one's going to make methamphetamine. My 60-year-old accountant's not going to be making methamphetamine out of the 5 tablets I give of pseudoephedrine. They come in 100,000 tablets from China. Nasal decongestants. Funny story, I've been approaching Pharmac to make nasal decongestants fundable, so we can give somebody something, so we can write a prescription, say, try this will work, because certainly they work when you try them yourself. And the evidence is a bit iffy. And they said, well, the PTAC say the evidence is a bit iffy on these. And I said, yeah, but we're actually giving placebos. We know antibiotics don't work. That's what people are getting. Let's give a placebo, perhaps with at least some subjective experience. So I give people a piece of paper saying, what to do with their cold. So antibiotics don't work, wash your hands, take time off work. Very keen to have people take time off work if they can, so they don't pass it to everybody else. Take paracetamol and non-steroidals. Evidence around that isn't great. Ipratropium, if they need it. Ipratropium nasal spray is quite good. It's funded. If they've got pure rhinitis, not so much if they're decongested. If they say, well, the other doctor, who's better than you, gives me antibiotics, I say, well, there's actually new evidence. It's now 3 or 4 years old. Massive studies from Europe. 10 days of Augmentin, 7 days of Amoxil making no difference, basically. And certainly not stopping anything like hospitalisations. Lower people's expectations. Coughs take 4 weeks to go away. Yeah. This could take up to 4 weeks to go away. Because people actually literally expect to be better tomorrow. The neat thing about decongestants is they feel better straight away. They feel better within a few hours. Time off work, possibly Vicks. Vicks has been shown in kids to help the parents get more sleep. And I must say, I love putting Vicks on when I feel dead. If you're going to give a delayed prescription, now what's going on in your mind with a delayed prescription? This person doesn't need an antibiotic, and I'm just trying to shut them up and get them out the door. Fair enough, we all have that. Just give it for 3 days, because they're not going to need it. If you keep giving 10 days to everybody, you're never going to find out how many people need 5-day prescriptions. I promise you, if you write prescriptions for 5 days, you'll never have anybody coming back saying, I need more. Virtually will never happen. But if you give 10 days, you're never going to know if they needed 5 days. And in most cases, they won't need the antibiotic whatsoever. Unless they've got pneumonia, that's a different ballpark altogether. And if you give a prescription, you're medicalising somebody. The evidence is absolutely clear they come back. We took over a practice from a guy who gave antibiotics to everybody for everything. And 8 years later, the patients still come in. They still come in, they want their antibiotics. And they tend not to, they only see me if they have to, but they try and pick the docs in the clinic who give the antibiotics, which is getting pretty hard. Effective treatments for a common cold, there's a podcast. You can get, if you haven't got it on your phone, you can go online and get it, and that's a talk by me. I will try and remember to add the common cold handout. It's actually in MedTech, so I can print it out. So I go and write common cold, and I can print it out. Okay.
Okay, this is based on basically the extent of evidence that we have. This is a much shorter one-slide presentation. And it's just, we get often to the point of thinking of last resorts. What are we going to do? And irritable bowel syndrome is one of those that can be quite frustrating. So basically we're looking now at the concept of the brain-gut sort of axis, looking at serotonin happening. And so these don't have necessarily massive evidence. On dancetrone, more so than the antidepressants. But so if you've got someone who's got the irritable bowel syndrome, things are a bit problematic, then consider on dancetrone. There is a good meta-analysis there that it could work in improving stool consistency. And if there's still an issue, as long as you tell the person this is not for depression, some of the antidepressants, there's sort of mixed information, but as I said, this is getting to a bit of a last resort. And there is some logic, just because, as I said, the brain-gut concept and the serotonin receptors that are in the gut. So that was really just a fast one to say, not good evidence, short slide, but last resort.
Okay, so antidepressants. These are showing you effect of antidepressants in mild to moderate, severe, and very severe depression. This is individual patient data. The middle column there is the active drug effect. In mild to moderate, it's 6%. The placebo on the next column is 47%. In severe, it's 9%. People get better, and there's 47% get placebo. In very severe depression, it's 25%. The placebo effect actually drops. So I think of the very severe as being a bit more chemical because there's less of a placebo response. Now, you may think those are pretty small numbers, 6, 9, and 25. They're probably an overestimate because the drug companies don't publish studies. So there's publication bias. And you might just have to take my word for this because we're running short of time. That big circle there tells you, this is a funnel plot on a meta-analysis. Sorry? This, I'm getting very excited about this. This is from our systematic review of primary care. So you can see the circle there which says missing small studies with no benefit. Over on the right, there are 4 small studies. So what's happened to the 4 small studies that show no benefit? Well, they're sitting in someone's drawer like me who did a small study and found they didn't work, and nobody will publish it. Very hard to get, in my world, getting a study published that's small, people don't like it, doesn't show any benefit, people don't like it. They sit in my drawer. So you probably find, you talk to a bunch of my mates and they'll tell you, in fact, Dee Mangan actually has a trial that sits in her drawer that wasn't, because the company wouldn't publish it because it didn't show any benefit. So, this is the real world. This is Kirsch, who got the trials from the FDA. And on the bottom there is severity, and on the y-axis is improvement, and you can see the lines don't start diverging until you get down to the very severe. So a PHQ-9 of 20 is about 28 there, those of you who are familiar with the PHQ-9. So this is very severe depression. So he found all the studies that were sitting in people's bottom drawer and wrote them and said, what did you find? And they said, we found nothing. And so he added them in there. So what are the harms of giving drugs? Well, they medicalise the condition. Any effect you get is going to be at least 8 times more likely to be a placebo response. And then they come back next year and say, my drug isn't working. Well, it probably never worked. They just got stressed again. They give the credit to the drug, not themselves. There's a risk of adverse effects. You're giving them the stuff they can kill themselves with. Just remember that. If you've ever had a patient swallow your pills, it's very sobering. I literally in Canada had to wash the pills out I'd given to a lady that I'd given the night before. She turned up in the ED department, and I had to put down the thing and wash out my tricyclics. I had asked her if she was suicidal. Interestingly, husband beat her up that night, and she decided life wasn't worth living, so I took the pills in the morning. Anyway, and they're difficult to stop, as Linda said, because of the withdrawal syndrome. Okay. When do they work? Severe end of depression. How do I know somebody's severe? They're not getting better. Okay. or they've had previous episodes. Of course, that's problematic because the previous benefit might have been through placebo. 12% of New Zealanders are on antidepressants. I think that's a bit too high myself. I don't think you should give them at the first visit. Tim Kennelly told me that years ago, and it's the best advice he's given me. Don't give antidepressants at the first visit. Most of the response is going to be placebo. Usually they get better by the next visit. If they're not, then you might want to think about antidepressants. We should be using sertraline and escitalopram as first line. We shouldn't be using, certainly not be using paroxetine or venlafaxine because of the withdrawal problems. And citalopram, which we use a lot in our clinic, has the QT problems. So sertraline's okay in coronary heart disease, and actually in pregnancy, not that we should be giving pregnant women SSRIs without external advice, I think. I wouldn't do that. But so we probably, sertraline's quite an easy drug to use, and well, I tend not to use a lot of it anyway. So we're probably
I think we're out of time, and that was just a slide, and all you have to do is remember when you mix opiates and benzos, people stop breathing, including with the Z drug.
Oops, sorry.
No, that's
okay, so thank you very much for coming. Fill in your feedback form, and hopefully 3 of you will be back here for certain next year, and we hope the rest of you are back. And thank you for making it such a wonderful atmosphere. I've had a great time. Thanks.